Hello everyone, hope you all are doing great. My name is Gazi and today I'm going to share a story with you which is just about one of the most wonderful and amazing things a human being can do in this world. And seeing the way that we can fix problems for people, hopefully it inspires you to accomplish your own goals, to get confidence in your own ability to make your dreams come true, and hopefully eventually be able to serve others. Also, for those of you who have family members who've had this procedure and needed a stent, or if you yourself may have had this problem, I hope you find this useful. Having said that, viewer discretion, of course, is advised. There's blood in the video as I'll be working on somebody's heart. So if you don't handle such content well, then please stop this video. Also, as a disclaimer, this isn't personal medical advice and it's purely for public awareness and the service of sharing information. The procedure you'll be seeing falls into the domain of what is called interventional cardiology, and I learned this specialty at Harvard Medical School. Currently, I live in Los Angeles, where I did further training in what's called structural interventional cardiology, where we replace heart valves at Cedars-Sinai Medical Center. My sincere thanks to the patient who agreed to share this video so that others can learn and get an experience of what it's like to have this procedure and for it to be done. As you'll see, her identity, of course, is protected and no personal information is shared. So as an introduction, she came in with a heart attack, which I diagnosed based on her story, her clinical presentation with chest pain, blood work showing damage to the heart's muscle based on enzymes called troponin, and an ultrasound of her heart which showed that her heart function had been reduced and a particular section or wall of her heart was not moving due to the damage that she had incurred. As you'll see here, all of that can happen when the blood supply to the muscle of the heart gets blocked due to a blockage of one of the heart's arteries called a coronary artery. As you know, a heart is a muscle and it needs continuous supply of blood and oxygen to keep contracting and pumping. These arteries, coronary arteries, supply that muscle with the blood that it requires, and if there's a blockage in them, there will be a reduction in the supply, which essentially strangles the muscle. If not fixed in time, the muscle will die, and this can lead to either weakening of the heart or death. Usually 100% blockages cause what are called ST elevation myocardial infarctions or heart attacks, which are treated like an absolute emergency, and patients are rushed to the cath lab, and things are moving as fast as possible, where every second is critical and not to be wasted. What you'll see here in this video is that I have time to speak to you and explain what's happening, because in her case, even though she did have a 100% blocked artery, she presented with what's called an NSTEMI or non-ST elevation myocardial infarction. Sometimes patients with 100% blockages can present with such NSTEMIs if they have what are called collateral blood vessels supplying some portion of the heart. There are three main arteries supplying blood to the heart to different regions. If one of them is blocked, sometimes blood can flow around coming from circuitous small channels from another artery to supply that muscle. And depending on how much collateral flow reaches the muscle, there may be lesser damage occurring to the muscle than there would have been had there been no collateral flow. She had a blockage of an artery called an obtuse marginal artery, which is a branch of the left coronary artery. And she had collaterals coming from the right coronary artery, which were compensating for that blockage to some extent, but not completely, because she did have damage to the heart muscle based on the weakening of the heart function, which we discussed. And the damage was also picked up on the blood work. You'll see how we get into these arteries via the wrist through the radial artery, where you take your pulse. And then you'll see how we use catheters to inject dye into the heart's own coronary arteries. As the dye is injected into these coronary arteries, we see if there are any blockages, where they are, how severe they are. And then, in her case, because she did have a 100% blockage, you'll see how I get through that blockage with a wire, use a balloon to open it up, and then use a stent, which I'll also show you, to keep it open, hopefully for decades to come. The whole procedure is done through the wrist going in from the radial artery, and once we're done, we put a pressure band on that artery for a couple of hours to prevent it from bleeding. Once we take it out in a couple of hours, we just put a band-aid, and the patient is able to stand and walk as soon as the sedation is worn off. And usually the patient can even go home the same day after the artery's been fixed, depending on the clinical context. The point of coronary interventions in the setting of a heart attack is to treat the heart attack by re-establishing blood flow to the heart's muscle so it can recover. to prevent further damage and death, which may have likely ensued if nothing was done, and to allow the heart function to hopefully improve with time. Again, as a warning, to those of you who may find these videos uncomfortable to watch, please be advised to look away or not watch further. For those of you who want to see how we accomplish this miracle of modern medicine, I invite you to share in the wonder of the privilege that we can have of saving another person's life.
We're here for a cat off of PCI, She has no known drug allergy. Was defined on the table of the virus level 1. Her last happened was shut off last night at 9:30. She had Belinda last night and aspirin this morning. Quags today were good.
Thank you.
You're welcome.
So we're going to try to get into the radial artery where the pulse is best felt. Ma'am, you're going to feel a bee sting in 1, 2, 3 poke. It's going to burn. So we'll puncture the artery and then get a wire into it so that we have access to the advanced equipment inwards. Can you get the table up, please?
Access 6 French.
Some pressure on your wrist here, ma'am. Make sure the wire is moving freely. Bring it inside. Advance the sheath. Pull out the dilator and the wires. Over here to secure the sheath. So we have the catheter here, and there's a wire that can be advanced up through the catheter. There's just a hollow tube, and then the wire comes out. It's got a J tip, so it's easy on the artery when it goes in. It's not traumatic when it pushes, and the wire will lead the way in towards the heart, and then we'll follow up with the catheter. And this is an empty tube, so we can inject dye going in and taking pictures. So it just goes slightly in, and then the wire goes up. 1 second. So we're going to look on the camera over here to see where our wire is going. So if the wire goes smoothly without resistance, then you're just going up the arm. And here, if you look over there on the camera, you can see the wire is going up the shoulder, and this is going towards the heart. Thank you. And this is now the wires in the ascending aorta. Next you'll see this tube coming up following along the wire. And we're going to try and get this wire across the aortic valve into the heart. Can you come in, please? And so the wire's in. I'm going to take the wire out, and now you see the empty tube is in there. You may feel a few extra heartbeats now. And now if you look here, please. So this tube is now inside the heart, the blood is coming out, and we connect the tube with a system through which we can inject dye and measure the pressures. So there will be a continuous column of fluid, and we can measure the pressures inside the heart by a pressure transducer that's over here on the first one. We are currently measuring the pressure inside the left ventricle. So next, we're going to take out this tube from the ventricle and go into the aorta. And that measures the pressure difference between the aorta and the ventricle to see if there's any drop in pressure in the aorta. This is an X-ray tube we use to see the contrast in the body. When we inject the contrast, that can be seen. So the tube right now is in the ascending aorta, and what we're going to do next is try to get this tube into the right coronary artery. And I've already injected contrast in the tube, so if we inject through the tube, it's going to be dark because the contrast is going to show up on the artery. now we're inside the artery. We're going to take a picture. So here, when we injected dye, we saw that this the APP. So the dye is filling up the artery, and we injected the dye through the tube. You can see already that there's a narrowing inside the artery, and then blood is flowing all the way across onto the left side, which is not normal. It's filling the left side from the right. But we can tell all of that just from one injection. So that means that there's probably a narrowing or a blockage on the left side of supply because it's being filled retrograde. Okay, press please. So here's another picture. We'll just take different angles. Third picture here, and now we're going to see the contrast going all the way across into the other artery. And based on that, we could estimate where the second artery is. Looks like it's the circumflex that's included. I disconnected this tube, and now we have the connection through which we were injecting dye through this syringe. And now there's blood coming back out from here, and we're going to go in with this wire that we initially used and take out the tube. And we're going to put in another tube to look at the left-sided arteries. So we put the wire in, and we just take it out. Now we keep the wire where it is. Thank you. So now a different kind of tube here. This is shaped differently. The wire will come out from the other end of this hollow tube. So here's that tube that we just put in coming in into the ascending aorta. And we make sure we check the pressure. We have good pressures, and then we can go ahead and inject some dye. And if you look when we inject dye, we're inside the artery on the left side. So let's go to arterial column. Now we're going to take pictures on the left side. So as expected, the circumflex artery is blocked. That's what we saw on the right side. Okay. We'll attempt to serve, please. We'll do angiomax. I'll take an XB35, please. Fixing it. I'll take a field XB, please. What we found is that you have a significant blockage in a main artery of your heart. It's pretty much 100% blocked, but there's a very thin thread of blood going through. So we're going to try and open it up, okay? And that's probably why your heart function went down compared to before. So we're going to go ahead and fix this narrowing. And this is a thicker tube. It's called a guide catheter, and it's shaped a certain way for this particular artery. And it's the same concept. We're hooked up to a pressure system, and through which we'll be injecting dye. And then through the back end of this tube, which is right here, once the wire comes out, we can insert a thinner wire to go across the narrowing, and then over that, we'll show you how the balloons work. If you can just show us the screen, please, for a second.
Yes, sir.
So here, that's the wire, and that's the thicker part is the catheter coming in. And we're going to try and get the catheter into the beginning of this artery supply. So we're going to blood in here. And then we fill this up with contrast, which appears transparent here, but it's dark once it goes in because it lights up on the X-ray. So here we have a wire. We're using a special wire which is made for this. Might be more likely to cross. You can see it's very thin, and we're going to shape it slightly so that it has some maneuverability. And we just basically put this wire in through the tube into the artery.
Feel nerves, Steve.
Basically, we'll be advancing the wire as you just saw. So we have the wire across, but we don't know if it's in the right place or not, because this is a very thin wire and it can easily dissect into outside the artery. Oh, that looks good. This looks good. Okay. Let's take a picture and we'll see what we're looking at. So if this matches up with the retrograde flow, we should be okay. And that looks great. So you see the tip of the wire meets up with the backflow from the other side, so we know we're at the right location. The big concern here is the wire tip shouldn't be somewhere outside of the artery, because then when you open up and dilate the vessel, you could tear it. So here it looks good. Okay, I'll take a 2 by 15 balloon, please. This is the back end of the balloon. This whole section is just giving it length so that we can advance the balloon into the vessel. And the tip of the balloon is right over here. I'll take that out. And then we have an indeflator, which is a way of suctioning back air and then using pressure to go up on the balloon, and it gives us how much pressure is being used, shows up on the dial. Then we hook up the back of the balloon. There's this 3-way stopcock. We go ahead and suction back with the indeflator so that the balloon is nice and tight as it crosses that blockage, because that blockage is very, very tight. The wire has gone through the blockage into the artery, and you just push it in and it will go straight in. And then you just advance the balloon forward. And then we push this forward, and you just leave it there. And then we'll make sure that the wire is where we want. And now we'll be seeing the balloon come in. If I was not sure where the wire was, I would be doing what's called a distal injection using an over-the-wire balloon. But I'm very sure I know where the wire tip is. As I advance the balloon, you're going to see it come in. And those 2 tips are the balloon. So sometimes if this blockage is very tight, it may not allow the balloon to go through, but we'll see. So that's the blockage. So it went through, that's good. Test. As soon as I take a picture, I'm pretty happy with where I am. I'm going to go up on this balloon. So we're going to go up on the balloon. This noise here is the indeflator going up. You see that the balloon has gone up. Where it was just 2 dots, now you see a dark shadow. Let's go down. So now we're going to take the balloon out and keep the wire where it is, and hopefully just open up the artery well, and we'll see what it looks like now. There you go. So it looks much better. Where you had no flow, now you've restored flow to this entire section. And at this point, we can go ahead and stent it. Pull the wire steady, pull back the balloon. So here's the stent. Same thing as the balloon. The only difference is that there's metal on top of the balloon here, which will stay open. This is also a balloon with a metal stent crushed on top of the balloon to keep it small so it can be inserted through our tubes. On the middle, so it's 2 dimensions, and then it'll be easy to thread it without seeing anything. It'll just go straight in. Okay, so the wire is going to come out. Put the stent in. So same deal here. And go ahead. Okay, the stent in. Go ahead.
I'm at 12.
So you see the stent is going up. So you see it's like a nice smooth lining. Everything is smooth. There's no pinch in the middle of the balloon, which means the stent is appropriately expanded. So I'm going to take a picture because this was near 100% blockage. There's a risk of perforation going from 99% blockage to open, and I don't see any perforation. So that looks good. 16. Good. Looks pretty good. Take out the wire.
Wire
Bottom catheter out.
And we're done. And then we have to just put a TR band. So we did this whole procedure. We were inserting all of our equipment through this tube over here. And we're going to basically take the tube out. And we're going to put pressure on top of it. So as I pull this out, I push in. And then we pull this tube out. And now she can move her arm. And she can sit up. And we're all done. We came in with a pretty much 100% blockage of the circumflex artery, and we open it up. It looks great, and this is exactly what we were hoping for. She came in with a heart attack, reduced heart function compared to a previous echocardiogram, and it was probably because of the blocked artery. We opened it up, so hopefully the heart attack is now going to be resolved, and the heart function is going to improve over time. Thank you so much. And we're all done. It looks great. I'm going to show you the pictures. If you remember this picture, where there's like 100% blockage going downwards, I'll show you the final picture what it looked like afterwards. This is the final picture. You see, that was 100% blocked, now it's nice. You see the difference? Good job. I hope you found that useful. Please share your thoughts in the comments section below, and if you liked what you saw, then please go ahead and share this with your friends so that more people can benefit from this content. And if you like this content, then please go ahead and subscribe to my channel so you can keep up with whenever I post the next video. For now, I shall say goodbye to you here from Bosnia and Herzegovina. Thank you for watching, and I will see you next time.